I am Dr. Purvi Chawla, consultant diabetologist and director of clinical research from Mumbai, India. On behalf of Diabetes and Women's Interest Group of Diabetes India, I welcome each and every one of you to this collaborative webinar with experts from the International Diabetes Federation Southeast Asia. Let me express my gratitude to Dr. Banshi Sabu sir, Secretary Diabetes India, and also the IDF Southeast Asia Chair-elect for helping us, guiding us, and facilitating this entire webinar today. And Dr. Amit Gupta, who's the Joint Secretary Diabetes India, for this wonderful opportunity that I will cherish as I lead efforts from this interest group. Dr. Rutul Gopani, my co-chair for Diabetes and Women Interest Group. We both are extremely overwhelmed and really happy that we are having this opportunity to host you all. And Diabetes and Women seems like a very or asking for equal rights or nothing of that sort. It is in fact all about highlighting the differences, sometimes stark and sometimes subtle, between men and women, and then appreciating different approaches to diagnosis, management, complication handling, and importantly, prevention of metabolic disorders in women. It is way before, beyond pregnancy, which is what prototypically we associate when we talk about diabetes and women. The group is vibrant and buzzing with ideas, and to quickly share, we have touched many aspects already that we plan to work on throughout this year. For example, nutrition, cardiovascular health, mental health to begin with. Today's webinar is an attempt it's just an attempt, like I said, to bring all these aspects together. And before I begin introducing our stalwart speakers, moderator, as well as panelists, I would like to quickly request Dr. Banshi Sabu sir, who is, and Dr. Amit to actually talk to us and quickly share their, words of wisdom with respect to this webinar.
First of all, thanks, Purvi, for moderating and planning and for everything what you are doing for this Diabetes and One program. This is a dedicated interest group of Diabetes and Women Special Interest Group, and I can see my elder sister Sabine from Pakistan, my good friend Dr. Dimuti from Sri Lanka, and I'm sure others will also join. As IDF Southeast Asia Chair-elect, we thought that we should have not only Diabetes India, but we should try to involve the people from Southeast Asia, and this how this webinar, what we are doing from Diabetes India Special Interest Group along with IDF Southeast Asia, just before 3 days of our National Congress of World Congress of Diabetes India along with Diabetes Asia Study Group, where we will be having more than 2,500 delegates and around 500 faculty from all across country, plus 50 international faculty. We will be missing our Pakistan friends because of the visa issue, and for that I am sorry that somehow we will not able to get your visa. The meeting of this type where we can connect with thousands of the doctors across the country and another thousands of the doctors from Southeast Asia. So I mean the online meeting is really a way by which we can reach out to the people across the country and across this part of the world. We have similar issues, and some of the issues maybe because of geography we may have different. So I think it will be really very nice that we will have meeting and inviting the faculty and the specialists who are from other countries. So we may have similar reasons, some issues are similar, and some of the issues may have specific to the region or specific to the country. With this, once again, Purvi and Rutul, who initiated this program, I am really thanking them. I am thanking our IDF Southeast Asia Chair, Dr. Ajad Khan sir, and Dr. Amit Gupta to coordinate from IDF as well as from Diabetes India, as he is the Joint Secretary from Diabetes India and plus board member for Southeast Asia. With this, once again, Purvi, I am really thanking you. I'm here and I will be joining once again in the panel discussion. Thank you.
Thank you so much, sir, for always giving us so much encouragement and guidance. I welcome Dr. Amit Gupta, who's a senior physician diabetologist from Greater Noida. And as you heard, he represents both Diabetes India as well as Southeast Asia IDF and many more, but his CV is endless. So without much ado, welcome, Dr. Amit. Please share with us.
Thank you, Dr. Purvi and Dr. Bansita for giving this opportunity. And as Dr. Bansi has just shared that our annual meeting it is less than 72 hours from now, and still we are doing this webinar and thousands of people have joined, and not only from India but also from the Southeast Asia region. So we welcome all of them. And so education never stops at Diabetes India, and I believe this is the motto of IDF as well. So I welcome all of you. And just to let you know about the interest group, so Diabetes India has 16 interest groups. And the membership of these interest group is open only to the Indian friends and Indian colleagues. Those friends who are in the other part of the world and other regions of the Southeast Asia, they are more than welcome to join us. And you can become part of this Diabetes and Women interest group, and you can connect with Dr. Purvi and Dr. Rutul. They will guide you more about it. And it is really nice to see all of you coming together and discussing diabetes in women in a broader context and not limiting the discussion only to diabetes in pregnancy. So welcome Dr. Dimuthu, Dr. Shabeen, Dr. Usha Shriram, and all the panelists today. And I will hand it back to Dr. Purvi for introduction of the speakers and conduction of the program.
Thank you, Amit. This was truly a fantastic initiative in the first place, and I think it took us some time to warm up. But I can tell you that the core team is really excited to take this entire interest group forward and do many more meaningful activities, with support from all of you. May I invite Dr. Rutul Goklani to now introduce our core team quickly before we start with the talks. Rutul?
Yes, ma'am. I'm here.
Go ahead, please introduce our team.
So, in Women and Diabetes, our team has Dr. Ami Sanghvi, who is from Mumbai, and she is practicing since last 18 years and faculty at various conferences. We know her very well, and her interest in diabetes and women-related diseases. Then we have Dr. Meenakshi Bajaj. She is dietitian at Tamil Nadu Government Hospital and multi-super specialty hospital. And she has more than 3 decades of experience in clinical nutrition. And Dr. Nimi Mulwani, she is consultant diabetologist from Ahmedabad. She has Dr. Nimi's Diabetes Care Center in Ahmedabad, and Dr. Ripun Borjapuri. He is a senior physician and diabetologist. With this, I'll hand over the session to Dr. Purvi Chawla.
Thank you so much, Rutul. We also have Dr. Abha Gupta from Meerut, who is a physician diabetologist with a very keen interest in diabetes and women. In short, the group is really alive, and may I now invite all our stalwarts from across Southeast Asia. I'm very thankful, keeping in mind all your busy schedules, who have still managed to be here for us. So without much ado, RX team, can we please have the CV slides? I take great pleasure in inviting Professor Shabeen Naz Masood. She is the Professor of Obstetrics and Gynecology from ISRA University and Medicare Cardiac and General Hospital, Jinnah Medical and Dental College, Pakistan. She is the Executive Committee member of the Society of Obstetrics and Gynecology of Pakistan. Also Vice President of the Diabetic Association of Pakistan, which is a WHO collaborating center, a board member, Health Research Advisory Board of Pakistan, an examiner for College of Physicians and Surgeons of Pakistan, with several publications in peer-reviewed international and national journals, author and editor of book on diabetes and pregnancy, past, present, and future of care, and recipient of the award from Governor Punjab for the services that she has rendered over the decades in the field of diabetes. Welcome, Professor.
Thank you, Purvi, for that very nice introduction and kind words. I already had sent my presentation. If you can run that.
We will be running that, ma'am. We're just introducing all our stalwart experts today, and then we'll go straight to the talks. We also have Dr. Deena Shrestha from Nepal, who's a senior consultant endocrinologist. She's at the Novik International Hospital, Siddhi Polyclinic at Kathmandu, and very well published in national and international journals. Her research interests include thyroid and diabetes in pregnancy, as well as obesity. And as of now, she is in Manila attending and making her presence felt there with respect to obesity and other metabolic disorders right there, right now. She has several achievements and awards, and she's the president of the SOF South Asian Obesity Forum and of the Diabetes and Endocrine Association of Nepal and South Asian Federation of Endocrine Societies, and many other important positions. She's a key player in this field, and we're very happy that even though she could not personally be there, she has sent us a recording of the talk. So thank you very much, Dr. Deena, for the same. And I welcome our next stalwart expert, Dr. Dimuthu Muthukuda from Sri Lanka. She is a senior endocrinologist and the past president of the Sri Lanka College of Endocrinologists. She is also the former secretary of Endocrine Society of Sri Lanka and founding secretary of SLCE, the joint editor of Sri Lanka Journal of Diabetes, Endocrinology and Metabolism of Sri Lankan College of Endocrinologists. She's also the executive committee member of the South Asian Federation of Endocrine Societies till date, and postgraduate trainer in endocrinology of Postgraduate Institute of Medicine at the University of Colombo, Sri Lanka. She's also the chairperson and guideline committee member of Sri Lanka College of Endocrinologists this year, and her research interests vary, and they include thyroid disorders, neuroendocrine tumors, Cushing syndrome, and hormonal assays as well. Welcome, ma'am. Welcome to this webinar. We are looking forward to your talk. And no webinar on diabetes and women can ever be complete without personality from our very own India, Dr. Usha Sriram, ma'am. She's truly a global name. She's actually a board certified endocrinologist who is based in Chennai, but has ramifications of her work globally. She's the president of the Indian Society for Bone and Mineral Research, founder of Divas, which has left massive footprints in this field, and we are all very happy to collaborate with her in this field again. Her special interests include gestational diabetes, women's health, osteoporosis, preconception care, medical ethics. And as I say, she has several strides in this field. She's made several strides in this field, and we are her followers and her soldiers, and very, very happy to have her with us today. So welcome, ma'am.
Just want to say I have a copy of Dr. Shabin's book, and it's an amazing book. She gave it to me at the IDF meeting last time. I really appreciate it and use it a lot. Thank you.
Great. So this is what such webinars do, help us network and collaborate, and we are learning, ma'am. So very happy in this esteemed presence. Tech team, if we can have the first talk, please.
Hello, everyone. Thank you very much for these kind words and the nice introduction. And congratulations and thanks to organizers of Diabetes and Women Interest Group, with a special thanks to Dr. Bansi Shabu and Dr. Purvi Chawla for all her coordination. Thank you very much for inviting me to talk on this Diabetes and Women Interest Group webinar. And with this, I would like to start my presentation about female sexual health in diabetes, and this has really been ignored for too long. These are my collaborative group of co-authors who had participated in this study. Sometimes some situation comes in the clinical scenario when your mind freezes and you stop, or you are forced to stop to think. Like this question, which was asked as doctor, can the uterus be transplanted back in my body? This question was asked by a desperate woman, 39 years of age. She was diabetic, anxious, and depressed. She had hysterectomy 2 years back. The spouse is disinterested in her and says that sex with a hysterectomized woman is like trying to animate musical notes from an empty drum. And according to woman, she says that she has probably rightly heard that a dead woman with uterus is better than a live woman without uterus. The sexual problems aggravated after loss of uterus to the lack of partner and concerns for catching disease. Another story is this couple, 26 years of age. They are married for 1 year, presented with non-consummation of marriage, requesting for intrauterine insemination. The spouse had opium addiction and she had erectile dysfunction. They wanted to prove that everything was all right and therefore wanted to have a child to prove to the world and to the family that they were having normal sexual relationship in marriage. Another couple, a doctor couple, presented with vaginismus and non-consummation of marriage for more than 1.5 years. This is just the tip of the iceberg. Advancement in the medical care, and especially diabetic care, has led to the issues of quality of life. But sexuality and aspect of quality of life, has this gained any attention in our clinical care? Human sexual function is an essential component of life, both in species propagation as well as quality of life. In a normal diabetic clinic or diabetic setup, we usually see screening, testing, eye clinics, kidney, foot clinic, educators. But have we seen any corner where female sexual health concerns are specifically addressed? So the objective of my presentation is that the healthcare providers should have a comprehensive understanding of the importance of female sexual dysfunction with chronic medical and gynecological disorders. And they should be equipped with knowledge to approach these cases with sensitivity and expertise. We know that with the advent of insulin in 1921, women with diabetes lived longer and they started having pregnancies as well. And as a result, for the next few decades, literature focused on the devastating effects of diabetes on maternal and perinatal complication, with a complete neglect on the influence of diabetes on both male and female sexual functioning. Issue of sexuality is a taboo in society. It was a taboo a decade back when Jocelyn, who was the first American physician to specialize in diabetes, he did not mention impotency in his diabetic manual, but did devote an entire chapter to marriage. But later, he had another book where he did address some facts about the sexuality, but he said that no diabetic boy or girl should get married unless they are ready to face the problems of diabetes with a smile. He further advised that marriage involves no danger for the man, but parturition does involve danger for the woman. And he further genetically advised that two diabetics should not marry and have children. Impaired sexual function in men is a well-documented complication of diabetes, and it was first addressed by Avicenna, the Persian physician and philosopher in 10th century AD. But sexual problems of women with diabetes are less clear and have received less attention than those of men. Discussing sexuality is unheard of. The philosophy behind it is that if you don't ask about it, it doesn't exist. In women, sexuality is still often viewed as equal to reproduction, which leaves the sexual issues unaddressed. About the physiology and psychology of human sexuality, Masters and Johnsons developed their linear sexual response model for the first time that consisted of sequential stages of desire, arousal, orgasm, and resolution. What is the importance of female sexual cycle response? It is an important education tool that clinicians can use when counseling women with sexual concerns. The importance of female sexual cycle is that a female sexual encounter may be inherent that she herself wishes to have sex, but a woman may engage in a sexual encounter for a number of non-sexual reasons. For example, to please her partner, to feel emotionally connected, or out of a sense of duty. She thinks that she is being provided with bread and butter, so it is her obligation to give sexual gratification to the partner. Females have unique health needs across lifespan, and they constitute more than 50% of world population. But when it comes to research about this sexual health and other health problems, the systems and cultures devaluate their experiences. The gender role expectations exerts a profound impact on women's sexuality. Silence as a way of maintaining innocence, or innocence is considered as ignorance. Women in our traditional societies are considered as undersexed individuals, submissive behavior, and have to be recipient of sex but not the initiators. And besides this, lack of acceptance by healthcare providers that sexual disorders matters to women with chronic illnesses, and besides personal taboos regarding sex, that is the confidentiality issues, worries about potential humiliation, and time constraints. The doctors are too busy. They are all suffering from, or most of them are suffering from, neck syndrome. So they don't have time to see the patients, to give them privacy, and to discuss these intimate issues. Women reported being more likely to disclose information about sexual health if providers did not make assumptions. They appeared non-judgmental, comfortable to talk, and respectful. All these qualities, unfortunately, are lacking in today's healthcare provider. Cultural differences are marked as far as female sexual dysfunction is concerned. Many women consider it embarrassing and private topic to discuss, and hence these sexual problems, they go unnoticed. And it is seen from this slide that 43% of the women in developed countries and 25% in Asian countries prefer not to talk about their sexual issues. And this can be because of the doctor's limited experience and our comfort in handling sexual problems. And this impedes the uncovering of possible sexual difficulties or disorders. And then these sexual issues are not prioritized in medical teaching or included in examination of the educational objectives. This female pelvic medical and reproductive surgery fellowship training milestones and American Board of Obstetrics and Gynecological Specialty certification include sexual function under general pelvic floor disorders as sexual health measures rather than addressing it separately. Now, what is the prevalence of these sexual dysfunctions? In women, the reported prevalence is between 25 to 71%, which there is a wide variation in the prevalence. This is because of lack of standardized definition and data free of socio-cultural contracts. That is the reason that a uniformly agreed definition is not there. However, DSM-5 changes in diagnostic criteria of sexual dysfunctions define it as all diagnoses except substance and medication-induced sexual dysfunction now require a minimum duration of approximately 6 months, as well as the presence of symptoms 75 to 100% of the time. That is, a minimum of 6 months of duration of sexual dysfunction is required for the diagnosis of sexual dysfunction. Considering all these things, we decided to have a cross-sectional multi-center study, and this is a published study. And in this, we use female sexual cycle dysfunction, and this was translated in Urdu, and this was pilot tested. All the questions in these 89 women, they were asked by our assistant professor in one of the diabetic department. And I have shared few of the slides from this study. The interesting thing about it is that 68% of the women, they received awareness about diabetes, and majority of this diabetes awareness was given by healthcare professionals. But when it comes about awareness regarding sexual relationship, 98% of the women said that they had sexual issues, but only 9% of them could discuss with their healthcare providers. A huge percentage, 91%, said that nobody ever discussed with them the sexual issues, though they were attending the diabetic clinics for more than 5 to 10 years. The prohibitors or deterrents of sexual health were children, small house, busy schedule, weakness, and pain. But lack of desire was found in 43% of the women, which is most difficult to treat. Similarly, if we look at the domain of female sexual cycle response, lubrication, orgasms, dysphoria, and those were present in about 80% of the women. Sexual desire arousal was present in 75% of the women, and this domain of female sexual cycle response is most difficult to address. What does data suggest from clinical trials conducted over 5 decades? It first started in 1971, and Claudny was the first to compare 125 women with 100 women without diabetes. And you can see all these studies published from time to time. And summary of these trials is that diabetes most frequently affects sexual arousal. Dyspareunia is present. However, the age, diabetes duration, and control, as well as its complications, have not been associated with female sexual dysfunction. Diabetes and its effects on female sexual dysfunction are multifactorial that can be interpersonal, psychological, sociocultural, biological, and pharmacological therapies. But psychosocial dysfunction is the most important of all, and many studies, like the one in Copenhagen, said that it is less linked to organic factors and more to psychological factors, especially depression. Similarly, another study from Iran said high prevalence of female sexual dysfunction was present in diabetic women with depression. Another study, which was done in University of Messina, said that psychological concerns were the major issues. Another study from Italy in type 1 diabetes is said negative impact of disease on socio-psychological factors. So, socio-psychological and cultural factors contribute to the possession of sexual dysfunction. There are no specific guidelines for the treatment of female sexual dysfunction in women with diabetes. And this was not the objective of today's presentation either. In brief, one can say that therapeutic approach to sexual dysfunction in women with diabetes, as they do not have a strict medical origin. Therefore, mistaken diagnosis may further complicate the management. There have been a number of potential and current therapeutic options available for the treatment of female sexual dysfunction, starting from sildenafil to estradiol to apomorphine, bupropion, and whatnot. But therapeutic approach to sexual dysfunction in women with diabetes, as far as concerned, pharmacotherapy alone, without addressing psychosexual disorders, have proven to be unsuccessful. In chronic illnesses, the partners who are suffering, there is a prevailing view that sex is the prerogative of young, fit, and attractive. Doctors need to recognize that people may be sexually interested, even though they may be old, ill, or disabled, especially the couples who are suffering from chronic disabilities or chronic medical disorders. Aging may affect sexuality and can diminish sexual desire and functionality. There is no age during which sexual activity, thoughts about sex or desire comes to an end. As is very rightly said, that sex has no expiry date. This book from our very good friend Deepak Jamani is available on Amazon, which says that sex has no expiry date. In conclusion, I would like to say that beware that sexuality is often a subject about which women or patients do not volunteer information. We have to think about our own capabilities and comfort to initiate discussion, to inform and manage sexual problems of the women. And besides this, female sexual dysfunction should be prioritized in medical teaching and be included in examination of the educational objectives. The idea of this presentation was to create ripples in our thoughts, in our practices, so that we could address female sexual dysfunction. I'm very thankful for your attention, and I hope that I have tried to create some ripples in the thoughts, in the practices, in the minds of our healthcare providers. Thank you very much for your patient listening. I would be happy to answer any questions if there are any. Thank you very much.
Thank you. Thank you very much, Dr. Shabin ma'am. What a wonderful lecture, as you covered almost everything which is possible, and the study was really striking. It is eye-opening that you showed it was from Pakistan, and that most of our HCPs, we don't ask the leading questions, and this is what the reason we don't come out with true data or the epidemiological data regarding female sexual dysfunction. And thank you very much for that. Also, the last thing that you explained, that there is no expiry date, and it is also very important that we need to understand that at any age, sexual desire or the thoughts of sex could be there, and then we should ask those questions to all of our patients. It is not regarded to age. So if we have any question, we want to take it right now, Purvi ma'am, or we can go ahead.
I think in the interest of time, we'll move ahead. We also have a panel discussion where some of them will be taken.
Right. Okay, thank you. So I would request Purvi ma'am to say a few words as for sponsors.
We all know that we need support for any such educational initiative as well. And we are thankful to Torrent Pharma to come ahead and support this educational initiative. And specifically Mr. Pandit for always being there to help us and support us. I also thank our organizer, who's hosting the event, which is RX Events, Dr. Hardik Chandrana and Ms. Neelam Chandrana. They are always, and the entire team with Ankit, Rishabh, Nankishore, all of them have been very, very supportive and helpful with respect to the webinar. Thank you so much. We can move forward.
Yeah. So our next topic is one of the most important topic, and still it is same like female sexual dysfunction. Somewhere it is cornered out, and we have very less talk. But it is very important as for pregnancy and its implication. It is very important. So thyroid disorders in pregnancy and its implication, and for that we have our speaker, Dr. D. Muthukuda. She is consultant endocrinologist from Sri Jayawardene Pura General Hospital, Sri Lanka. Over to you, ma'am.
Good evening. So thank you very much for that introduction. So can you see my slides? I have shared.
Yes, ma'am, it is visible.
Okay, so first of all, I would like to thank the organizers of this webinar, Diabetes India, along with Southeast Asia IDF, and in particular, Dr. Banshi Sabur and Dr. Purni for inviting me to deliver this talk. So I'll be talking about thyroid disorders in pregnancy, which is a very important topic because thyroid disorders are not uncommon during pregnancy. And we know how important it is to have, a normal functioning thyroid gland during pregnancy. In particular, we are very much worried about, having a proper neurocognitive development of the offspring. So everyone knows that there's a very strong association between the thyroid gland functioning and the long-term outcome with regard to the IQ of the offspring. And so it's why it is the very reason for talking about thyroid dysfunction during pregnancy. And it's important to note that by about 10 to 12 weeks of gestation, we do see a functional thyroid gland in the fetus, but it's known that it does not fully mature until about 18 to 20 weeks of gestation. So therefore, during the initial part of the pregnancy, the first half of the pregnancy, the fetus is like almost totally dependent on maternal thyroxine, which is delivered through transplacental passage across, to the fetus. And as I said, it is important for early neurocognitive development of the fetus. And I've listed out, some of the adverse outcomes which we see in the mother and the fetus. Both together we consider as one single unit, during pregnancy. As a result of improperly treated or untreated thyroid disorders in pregnancy. So I've mentioned here outcomes due to hypothyroidism and hyperthyroidism. So I'll go through quickly some of the important consequences of not being treated properly. Hypothyroidism can give rise to, from on the maternal side, gestational hypertension, recurrent pregnancy losses, and so many other complications. And in the fetus, neurocognitive impairment and a lower IQ, low birth weight, IUGR, stillbirths. Hyperthyroidism equally can give rise to maternal complications such as gestational hypertension. And in the fetus, depending on the duration, can give rise to fetal tachycardia, a fetal goiter, and later on, even neonatal thyrotoxicosis. And the next important thing is to understand about the thyroid physiology, because pregnancy in a profound manner affects the thyroid physiology. So without having a proper understanding of the thyroid physiology, it's very difficult to interpret the TFTs in pregnancy. So as a result of which might give rise to wrong interpretations and inadvertent treatment. During pregnancy, the demand for thyroxine increases by about 50%. So it has to be remembered. And as a result of that, the iodine requirement also increases. And on the other hand, there's another reason for that. During pregnancy, the renal clearance of iodine increases. Therefore, outside pregnancy for a woman, about 150 mics is needed. And for a pregnant lady, it's about 250. So there's a great increase in the iodine requirement during pregnancy. The other important thing that happens during pregnancy is the effect of the HCG on the thyroid gland. So we know that there's molecular mimicry. The alpha subunit is common to TSH and HCG. So therefore, HCG has a weak thyrotrophic effect on the thyroid gland, giving rise to an increase in the thyroid hormone production, and as a result of which we see a suppressed TSH level, so which is a physiological phenomenon which takes place in pregnancy. And the other effect, the main effect on pregnancy, is the high levels of estrogen, so which causes a twofold increase in the thyroxine binding globulin, the TBG level. So an increase in the TBG level gives rise to an increase in the total T4, T3 concentration. And the levels peak by about 16 weeks of gestation, and it remains to be high until delivery. So I've illustrated those changes in this diagram. And then we need to understand about the TFT physiology, thyroid function tests. So the graph very clearly illustrates how the TFTs fluctuate during pregnancy. So if you look at the line in blue, light blue, that is TSH tends to drop gradually towards the end of the first trimester. So as you can see, it drops gradually. And then towards the second and the third trimesters, it tends to recover. It tends to come back to the pre-existing levels. But we need to remember that this may not happen fully. So from time to time, we see women whose TSH remains to be suppressed throughout the pregnancy. So this is the normal curve for TSH. And then let's look at the free T4 curve, so which is shown in red color. So in the first trimester, we see a slight increase in the T4, and then it gradually drops towards the latter part of pregnancy. And it's important to note that in some women, it can even drop below the reference range. So that also can happen in physiological conditions. And then we look at the two shades of green color. So that's the TBG and the total T4. They go in parallel with each other. TBG level, both tends to increase gradually up to about 16 weeks, and they remain to be elevated throughout the rest of the pregnancy. And then the HCG level, as expected, it rises at, up to about the latter part of first trimester, and then it gradually comes down. So if you carefully look at this graph, the HCG and the TSH, it mirrors each other. So if you carefully look at the graph, so we need to understand about how the TFTs fluctuate during pregnancy for us to be able to interpret the TFTs. And another important thing that I would like to highlight at this stage is that the TFTs in pregnancy can differ, and it differs depending on the ethnicity and the iodine status of the population, and also the laboratory standards, the assay being used. And so I've mentioned that, we expect a lower TSH during pregnancy due to the HCG effect. And because of this phenomenon, the American Thyroid Association and, other organizations recommend using, this is very important to understand. The recommendation is to use population-specific, assay-specific, and trimester-specific ranges for TFTs in pregnant women. Otherwise, we could be misled. In the absence of population-specific reference ranges for a particular area, the recommendation is to reduce the lower limit of TSH by 0.4 and the upper limit by 0.5. And it would correspond to the TSH reference range of 0.1 to 4. during T1 with a gradual normalization towards T2 and T3. So as I've listed out the US-based normative data, and if a particular region does have population-specific data, might as well go by those, in the absence of which we can go according to these recommendations. So out of interest, I've shown one of our publications, which was done some time back. Our group developed normative data, trimester-specific normative data for TFTs for Sri Lankan women, and it was published a couple of years ago in Ceylon Medical Journal. So this is the spectrum that I'm going to talk about, thyroid disorders in pregnancy. We have overt hypothyroidism, overt disease, hypo and hyper. We have subclinical disease, hypo and hyper. And there's another entity called isolated hypothyroxinemia. And we have thyroid nodules and thyroid carcinoma and postpartum thyroiditis. So very briefly, I'll go through each of these conditions. So we know what overt hypothyroidism means. So it's a high TSH along with a low T4. And the prevalence is said to be about 2% to 3%. And out of that, overt is very much less, 0.3 to 0.5. And much commoner would be subclinical hypo. So that's about prevalence. And we know how important, having normal thyroid hormone levels during pregnancy. In regions with adequate iodine nutrition, now Sri Lanka, we are an iodine replete nation. So, but here and there, deficiency, pockets may be found. Autoimmune thyroiditis or Hashimoto's thyroiditis is the commonest cause for hypothyroidism. And the antibody, TPO antibody and thyroglobulin antibody positivity is said to be very significant. These data are from the Caucasian populations, but even in our region, I assume that the levels should be, similarly high. So antibody positivity may be there in hypothyroidism due to Hashimoto's thyroiditis. And it's a known fact that underlying thyroid autoimmunity, it seems to be having an additive or a synergistic effect on miscarriage and prematurity, autoimmunity along with hypothyroidism or subclinical hypothyroidism. So for overt hypothyroidism, the target TSH during pregnancy is around less than 2.5 would be the target. We can go for a slightly higher target during the rest of the pregnancy. And initially, TSH should be checked 4 to 6 weekly, and we can lower the frequency thereafter. And it's important to preconceptional advice is very important for those having pre-existing hypothyroidism. And the moment pregnancy is diagnosed, the dose needs to be increased at least by about 30%. To be able to keep up with the demand of pregnancy. And in those who do not have an endogenous thyroid production, such as after radioiodine ablation or surgical ablation, those women would need a higher dose, even more than 30%. So that's a little bit about hypothyroidism. Now, this is an important question. Is universal screening indicated? The answer is right now, no. At present, no. Why? Because the data, the published data, had not shown cost effectiveness in screening for thyroid disease universally among pregnant women. However, what needs to be done is case detection, not universal screenings. What it means is that you need to know what the risk factors are for developing some sort of a thyroid dysfunction or to be having some sort of a thyroid dysfunction, such as family history of thyroid disease, other presence of other autoimmune diseases, elderly age, prior neck or neck surgery or irradiation, morbid obesity, use of certain drugs. So you need to be very familiar with the list of risk factors, and you need to do case detection actively and manage accordingly, but universal screening is not indicated right now. So what about subclinical hypothyroidism? It is an important entity because it is the commoner out of the two compared to overt. and the effects of subclinical. Having said that, we need to understand that the effects of maternal subclinical hypothyroidism on obstetric outcomes still being debated. So several observational studies have found no association between maternal subclinical hypo and outcomes, listed here. On the other hand, some of the other observational cohort studies have found some association between maternal subclinical hypothyroidism and the consequences, pregnancy loss or miscarriage. So based on all these data, we can come up with actually shown here the American Thyroid Association recommendations. So I'll go through very briefly. If in TPO antibody, now I've forgotten to mention one thing. If you detect an abnormality in the TSH, in some women, you need to do the antibody status. You need to check for the antibody status. So we call it reflex checking of the antibody status in some women. So if in the presence of antibody positivity, and if the TSH is greater than the pregnancy specific reference range, let's say that it's more than 4, in the presence of antibody positivity, thyroxine therapy is recommended. And if antibodies are negative with a TSH greater than 10, still thyroxine treatment is needed. Antibody positivity, TSH above the pregnancy specific reference range, that is, let's say, above 4, treatment is needed. Antibody negativity, TSH greater than 10. And TPO positive with TSH 2.5 and 4 also, thyroxine therapy may be considered 2.5 and 4. And antibody negative, TSH 2.5 and 4, or let's put it in another way, less than 4, it's not recommended. So that is the summary of the recommendations based on the TSH value and the antibody status. So let's go on to the next entity. So I showed initially, that is isolated hypothyroxemia in pregnancy. So by definition, so that's a state where we see low levels of free T4 along with a normal TSH. So that's called isolated hypothyroxemia in pregnancy. It was recognized not long ago. So the effects of this condition on pregnancy outcomes remains to be unclear. Therefore, international organizations, including ATA, currently does not recommend thyroxine treatment for this particular condition. So very briefly about TPO antibody levels, because now it has been incorporated into the guideline. It's good to understand about this the condition. Antithyroid peroxidase, it's considered as a marker of thyroid autoimmunity. And the prevalence, as I said, it's said to be very high, very significant, 5 to 14%. And along with subclinical hypo, there is an additive or a synergistic effect on the outcomes. However, TPO antibody positivity alone, without having an euthyroid status, treatment is not indicated. So I'd like to say that again, being euthyroid, having high TPO levels, treatment is not indicated according to what has been shown in published data. So that's about TPO antibodies. And again, I have summarized how the management has to be done. And then just on the left-hand side, if you happen to diagnose overt hypothyroidism, it has to be treated urgently. And the goal would be to normalize TSH as soon as possible, keeping in mind that the goal would be less than 2.5, and close follow-up with TSH, frequent TSH, maybe 4 to 6 weekly it's indicated. Then let's move on to overt hyperthyroidism in pregnancy. So this again is a very important entity because a lot of confusion happens. Between these two conditions, Graves' disease versus gestational transient thyrotoxicosis in the first trimester. So those are the two most common causes of hyperthyroidism in pregnancy. The prevalence is said to be, it's not that common Graves' disease when you look at the these figures, whereas GTT ranges from 2 to 11%. DGTT is an exaggeration of the HCG effect on the thyroid gland. Having a suppressed TSH, it's physiological. So an exaggerated form where, it could be due to twin pregnancies or could be due to hyperemesis. Sometimes free T4 can go up, causing gestational transient thyrotoxicosis. So the distinguishing between these two forms is important. Unless you do that, we might get misled and, the wrong management could be instituted. Patients with Graves' disease, they would have Graves of thermopathy, and the ratio between T3 to T4 is important because Graves would produce preferentially T3. So therefore we can look at the ratio, and there could be a goiter with increased vascularity, and most of the patients TRAB would be positive. But even then, a proper differentiation and accurate differentiation between the two conditions could still be challenging. And another thing that I'd like to highlight here is that pre-existing Graves' disease would get better towards the latter part of pregnancy because of the immunosuppressive effect of pregnancy. So treatment options for Graves' disease in pregnancy, you need to think about teratogenicity of antithyroid drugs, and especially if we are to use these drugs, preconceptionally and, during the first trimester. Carbimazole, methimazole is considered, being contraindicated in T1 due to potential teratogenic effects. And if you compare the teratogenic effects of PTU versus, the effects due to methimazole, we see a more significant or more, profound effects due to methimazole. Therefore, PTU is the preferred drug during the first trimester, and once organogenesis is over, after about 12 to 14 weeks, we can always convert to carbimazole. And we need to remember that these drugs cross over to the fetus, crossing the placenta, it reaches the fetus, and, you can get fetal goiters. Therefore, if we are to continue with ATDs during pregnancy, we need to give the lowest possible dose for the shortest possible period, and it has to be done by a specialist very, very extremely carefully. So it is very important to avoid over-treatment of hyperthyroidism in pregnancy, a lot of adverse consequences. And the ATA recommends, having a maternal level of free T4 at a high normal level, or even could be mildly elevated, and we shouldn't try to normalize. We shouldn't expect free T4 to drop to very low levels when treating hyperthyroidism in pregnancy. And usually we go by free T4 because TSH would be anyway suppressed. So we are not expecting the TSH is not expected to normalize in pregnancy. So free T4 should be monitored every 2 to 4 weeks until you reach a stable dose of ATDs. Then we can reduce the frequency of monitoring. And as I said earlier, thyroid autoimmunity tends to improve in the second trimester, and it gets better. But after delivery, it can again recur. And one important thing, block and replace strategy is not used during pregnancy because more than thyroxine, ATD crosses over to the fetus. So therefore, that method is not recommended in pregnancy. So short-term beta blockers could be used for symptomatic control. And if the mother is unable to tolerate antithyroid drugs, or there are severe symptoms which, if you find any difficulty in controlling symptoms, very rarely even thyroidectomy could be considered. And, the preferred period is the second trimester. And we need to remember that if TRAB is positive, it can cross over to the fetus and can cause fetal hyperthyroidism and even a goiter. So we can anticipate, the neonatologists could be informed early on about it so that they can expect neonatal transient hyperthyroidism in the presence of high TRAB levels. So from time to time, first trimester, again, second and third trimester, we can check for the titers. So subclinical hyperthyroidism in pregnancy, it's a very important entity because this clinical picture, the biochemical pattern is very common during pregnancy. So things could go wrong here because a lot of people, I mean, at several various levels, clinicians look after pregnant women and they see TFTs and people, they can get misled with a suppressed TSH with normal T4 levels. So we should be able to differentiate between, what we see due to the normal physiology, a suppressed TSH as opposed to gestational thyrotoxicosis, again versus some other reason, Graves' disease causing subclinical. So sometimes it may be really challenging, the differentiation. And the HCG effect would peak, between the latter part of T1, somewhere between 7 and 11 weeks. And studies have shown that subclinical hyperthyroidism is not associated with adverse obstetric outcomes. So subclinical hyperthyroidism due to, maybe Graves' disease, or it could be gestational thyrotoxicosis, or just suppressed TSH due to the HCG effects. Therefore, we should not treat subclinical hyperthyroidism in pregnancy in a generic manner. So what about thyroid nodules in pregnancy? So the prevalence is said to be around 3 to 30% depending on the iodine intake. And the older the mother, the higher the risk of having thyroid nodules. And, the excessive or low iodine nutritional status, both ends, the risk of having nodules would be higher. And, multiparous women, higher chance of having nodules. So another thing that I would like to highlight is that the thyrotrophic effect of HCG can nodule size might increase during gestation due to the thyrotrophic effect of HCG. So just like what we do outside pregnancy, thyroid ultrasonography is the best imaging modality for evaluation of thyroid nodules, and FNA biopsy also could be done safely during pregnancy. Molecular testing is not currently recommended because it has not yet been validated for pregnancy. So thyroid nodules, just the basic principles, just that, we have to be very objective in evaluating. A lot of unnecessary tests should be avoided, and we have to be very logical and, realistic in, carrying out these investigations. So what about thyroid cancer in pregnancy? Thyroid cancers are not that uncommon, among, young females, females who are in the reproductive age group, and certain cancer registries have shown a prevalence of about 14.4%. And what we need to remember is that a lot of neck imaging is being done nowadays. So because of that, more and more micropapillary carcinomas are being diagnosed. Therefore, it's not an uncommon scenario to see, someone coming with a diagnosed thyroid cancer in pregnancies. Therefore, the standard, the principles should be followed, and unnecessary surgeries, during pregnancy should be avoided. And if it's really needed, then, the T2 during the second trimester could be considered. But, you need the multi MDT, the discussions need to be done, in managing these complex conditions if you happen to see during pregnancy. So what about those with a history of thyroid cancers? Now, I mentioned that thyroid cancers are being diagnosed, more and more during the last couple of, 1 to 2 decades, maybe, the previous decade. So because of that, a lot of young people enter into, they conceive, and, and we, as physicians, endocrinologists, we see a lot of pregnant women, who have been treated for a thyroid cancer, are being followed up in our clinics. This per se shouldn't discourage, having a thyroid cancer per se shouldn't discourage people, from, conceiving, from, pursuing pregnancy. No significant adverse, pregnancy outcomes have not been shown, people who have had a history of thyroid cancer. And, women who have had an excellent, outcome, a good response to treatment tend to do better during pregnancy without having a significant enlargement or a recurrence or any adverse effect, whatsoever during pregnancy. So we shouldn't discourage young women from, shouldn't discourage them from conceiving just because of the thyroid cancer history. So let's move on to the last entity, that is postpartum thyroiditis. Postpartum thyroiditis, again, it's not an uncommon condition, and it's a type of a destructive thyroiditis. The prevalence is said to be about 5 to 8% of women, and usually we see this within the first year or the first 12 months after delivery. And etiology is thought to be a rebound of underlying thyroid autoimmunity occurring after the immune tolerance induced by pregnancy has ended. Now, as I said earlier, there's an effect of immunosuppression during pregnancy, and after delivery, it ends. The suppressed autoimmunity ends, and there's a rebound effect of immunity. So, because of that, especially people who are prone to getting thyroid autoimmunity can go into this condition of postpartum thyroiditis, and it's mostly seen in women who are positive for TPO antibodies or those with personal or family history of autoimmune diseases. So the classic presentation would be with thyrotoxicosis within the initial couple of weeks, 4 to 8 weeks of delivery. Because it's a destructive condition, there's release of preformed thyroid hormones from an inflamed thyroid gland, and there's a state of transient thyrotoxicosis, and it would last for about 1 to 2 months, and it could be followed by transient hypothyroidism, which could last for a longer period, maybe 4 to 6 months, until the thyroid gland recovers. And about 25% of women would have a thyrotoxic phase, and 50% of women would only have a hypothyroid phase. It's a spectrum basically, and this condition, postpartum thyroiditis, could recur in subsequent pregnancies. Also up to 70% of could recur. So anti-thyroid, the important message is that anti-thyroid treatment is not indicated during the toxic phase, because just like subacute thyroiditis, it's a transient phase and it will recover on its own, and it's a destructive type of thyroiditis. And the symptomatology could be managed with beta blockers. Thyroxine could be given for the hypothyroid phase if they are symptomatic, or if they are biochemically very much hypothyroid, and if they're actively trying to conceive, then thyroxine could be given for a period of time, and after about 6 to 12 months, it could be slowly tapered, because the natural history is such it improves gradually. However, TSH should be monitored during subsequent pregnancies, because the rate of recurrence is very high. Thank you very much for your attention, and I would like to come up with these, the messages. I mean, this is for insightful thinking. Establishment of local policies for the management of thyroid disease in pregnancy should be, it has to be a topic which we need to talk about. We need to have local, rather than having ad hoc management methods. We have to have local policies for the management, investigation and management of, evaluation and management of thyroid disease in pregnancy, and these need to be incorporated into routine pregnancy care. For example, when and whom to be screened, when to refer for specialist care, etc. The other message is that we need to have a sustained education method for healthcare practitioners, including general practitioners, to prevent inadvertent treatment, such as for, treating with antithyroid drugs for physiologically suppressed TSH in early pregnancy. So from time to time, we do see such an occurrences. And another point I would like to highlight is that, we need to encourage, the laboratories at a national level, especially, I'm actually thinking about the Sri Lankan scenario, to provide trimester-specific normative data. It doesn't matter not having our own data, but at least, those that are meant for the Caucasian data, if we can have in our reports, then the person who interprets would know that, this is, you have to there's something that you need to learn about, or you need to discuss about these. About the interpretation. And most of the time, what happens is that when the pregnant mother gives blood, in the laboratory, they wouldn't know that this is a pregnant woman, so that they wouldn't anyway have the normative pregnancy specific data in the report. So clinicians, in general, they tend to just, interpret according to the standard data. And the other thing is that we need to encourage effective networking between specialists in this field and the rest of the team of caregivers, to ensure that there's a smooth in long-term management of the pregnant women. And also, the most importantly, I would like to highlight the fact that we need to have collaborative research, among the stakeholders in this region, to understand the characteristics of our own region, ethnicity-specific population in South Asia, and along with development of guidelines. So with that, I would like to conclude my presentation. I would like to thank again, for inviting me to deliver this talk to you. Thank you very much.
Many thanks, Dr. Dimuthu. It was such a fantastic review and insights shared on thyroid disorders during pregnancy. And I think the nuances that you shared really clarified some of the myths that we have around managing these. So thank you for that, especially the antibody testing, which is not very commonly done in India. And also the guidelines stand on universal screening. There are there are country to country differences, but thank you for highlighting some of them. And the choice of drugs, especially in hypothyroidism during pregnancy. So very, very comprehensive talk, and thank you for beautifully reviewing the same. There's a slight change now in the format. We are moving on to the panel discussion, and we have a wonderful panel of experts. And I hand over to Dr. Usha Sriram, ma'am, to introduce the topic as well as take it forward. Ma'am, I'm at your service if you want me to.
Wonderful moderator, We have the more eminent moderator.
Thank you, Purvi. And first, thank you for this, opportunity to be part of this program. And what a great panel you've given me. You've given my younger brother, Panchi, and I understand that Dr. Shamugavelu is not going to be here today, but I have Dr. Shabin and Dimuthu and Panchi. I can't ask for a better panel. And you're all there as well, so jump in. This should be a really interesting discussion. So the topic that we are going to discuss today, and I think it's very fitting for the inaugural program, which is pregnancy as a window to future health. And then so I've left it as future health and didn't say mother or child because it actually impacts both of them, the mother and the child, and also future generations. So when we are talking about high-risk pregnancies, really it's a window to future health of not just that mother and that baby, but many future generations. I'll just make this into a slide presentation. So very grateful for the panel. As you can see, only Dr. Shamugavelu is not here. I'll just show a couple of slides. So when you look at non-communicable diseases in women, which is what we call chronic diseases, and we are just with women, if you look at the risk factors, it's not just things like hypertension, obesity, dyslipidemia, or diabetes. But if you look at the panel on the right side, anybody with an adverse pregnancy outcome, like hypertensive disorders of pregnancy, gestational diabetes, preterm delivery, placental abruption, small for gestational age baby, someone who's had miscarriages, someone who's had an IVF pregnancy, all these people are at greater risk for future cardiovascular disease and other chronic diseases. So in a snapshot, if you see, if someone has gestational diabetes, I'm going to ask the question to Panchi. or hypertensive disorder at 30. In 5 to 10 years, they develop type 2 diabetes, a big chunk of them. And then 1 out of 3 develops chronic hypertension. And then you go a little further, they develop stroke and heart disease and kidney disease. So the point I want to make here is when you say 5 to 10 years and 15 to 20 years, this feels like far away, but the pregnant woman is in her 20s or 30s. So we're really talking about this person developing all these complications, possibly even as early as her 40s and 50s. So it is something seriously to be taken into, which is what we want to do for them not to progress. And one other important fact before we go to the question is, each time you have one of these high risk complications, and if they happen together, like a preterm delivery and a small baby and a hypertension mom, 1 plus 1 plus 1 becomes 10, not 3. So they're additive when they happen together. So that's another important point to keep in mind. And we've always been very myopic when it comes to maternal health. We're only looking at delivering and giving her a healthy baby, and after that, she's forgotten. After that, the baby also is only in a well baby program. We're not thinking about if this baby comes from a mother who had, complications or was nutritionally deprived. We don't know. So, start with Dr. D. Murthy. Is obesity a big challenge for women during pregnancy nowadays? And what kind of risks are you seeing associated with obesity?
Yeah, thank you, Dr. Sriram. As the question is obesity a big challenge for women during pregnancies? I would say that the simple answer is yes. So we know that, obesity is such a huge problem, especially, it's a global issue, but especially for this particular area, the South Asian region, along with insulin resistance. Those two conditions, insulin resistance, obesity, and the other metabolic conditions, such as GDM, type 2 diabetes, and various other components of the metabolic syndromes. It's such a huge challenge in this region. And we know that, can you go to the next slide? Insulin resistance, obesity, those are inflammatory conditions. So, that have been shown in, recently performed studies, inflammatory conditions, all the insulin resistance and obesity. So, during pregnancy, starting, and as Dr. Sriram said that, it's just a continuum, starting from a baby girl, along the growth, along the timeline, when the girl reaches adulthood and then subsequently motherhood, it's sort of a continuous cycle, and along the entire cycle, obesity affects adversely. And during pregnancy, these are some of the complications that could be anticipated due to, directly due to obesity related effects. Subfertility, miscarriages. We know that the incidence of polycystic ovarian disease is a complication, directly related to obesity. So as a result of which we see these complications. And then gestational diabetes, hypertensive disorders, various other complications such as preterm birth, labor complications, cesarean section. So all, numerous complications. And it's not just the mother, the maternal effects, but, fetal outcomes also could be affected adversely due to obesity. And, it had been shown that it can give rise to congenital malformations. The risk is higher. And, macrosomia is expected. So as a result of which, a lot of mechanical issues at the time of delivery, and even, can give rise to stillbirth. So maternal and fetal complications. And postpartum outcomes, when it comes to the mother, can give rise to, severe hemorrhage, infection, venous thromboembolisms, I mean, could be serious, some of these complications. And, the breastfeeding also could be affected, negatively, and, a lot of psychological issues such as depression. And long term, that's why I said that it's just a continuum, not just, restricted to the pregnant period, but it can give rise to long-term consequences as well. So weight retention and obesity, long-term obesity, associated with rest of the components of the metabolic syndrome, such as hyperlipidemia, type 2 diabetes, ischemic heart disease, hypertension, stroke, obstructive, you name it, and it will be there due to obesity. So I think it is a serious problem, that in particular, I mean, not just in women, but I mean, since this is a webinar too, I mean, we are talking about, women's health. So, I mean, it is a serious issue. And in this particular area, the obesity pattern also would be different from, what we see. I mean, maybe different to what we see in, the rest of the world. The pattern of obesity, the pattern of, fat accumulation in the body and the degree of insulin resistance. So we need to collectively, the nations need to get together and we need to do something collectively for the increasing prevalence of obesity in our area.
And this one is a study from actually South India, which shows that all this we are talking about are actually, significantly present in women who are overweight and then get pregnant. I just circled the GDM, how big of a problem it is in an overweight person, obese person, as opposed to a non-obese person. So thank you so much for that, very answer. Vanshi, gestational diabetes is rising so rapidly. So the problem is they're not able to follow these women with GDM, or even postpartum, and then what about this lifelong follow-up to prevent future diabetes and other complications?
So first of all, thanks, Usha, for asking me. This is very important that GDM is rising rapidly, and this is really very, very true in last couple of decades, rather, I will say. And you are the first one to talk about the gestational diabetes, the window of opportunity for throughout the lifetime that we can prevent the persons to develop diabetes. So that's what we learned also in our clinical practice too. So GDM first, that the rising rapidly, one of the reason is obesity itself is a one major challenge for that. It starts with the pediatric obesity. Young adolescents, girls are becoming obese, then they develop PCOS, they have all metabolic syndrome, all other reasons for that. Other also, the Southeast Asian origin also itself is a major risk for them to develop GDM2. Now it's more detected early, as with the DIPSI criteria which we use, or it has become very easy for us that first at any antenatal visit, we check the sugar. We, throughout the country, we had educated our gynec friends also that they do. So that, there are multiple reasons for that. And it's definitely incidence is very, very high, and we started treating them aggressively too. But the challenge is the following these women with GDM. Because what happens once they develop GDM or hyperglycemia in pregnancy, they are very, very regular to the doctors. They go to the, even if a obstetrician friend will say that you go to diabetologist, they will come to you and they will follow you, whatever you say. You ask them for CGM, you ask them for diet control, you send to your nutritionist. They will do all those follow. And even if you ask them to take 4 times injection, 4 times to sugar to be checked, they will do. Immediately postpartum, very few women will go back to the doctor if their sugar is normal, that is immediate postpartum, and they will, even you explain them multiple times during this antenatal visits to your clinic, and you might have seen them 4 times, 3 times during this time or 6 times. You always tell that, this is a very strong reason for you to have a diabetes postpartum. After that, you will develop it. And this is the time that you should learn that how we can prevent diabetes, how we can prevent obesity and all those things. But even still, I am seeing in my own clinical practice that very few people will come back to you. Will come back to you and ask that, how I can now, because I gained some weight, or how I can see that in my future I will not develop the diabetes, or how regularly I should follow my sugar to be tested regularly. I normally recommend, yes, that's fine, that annually you check up for them for the sugar, because that is what is recommended also in India as per the guideline, that every above the age of 30, they should be checked, because all of them, and if they are obese, if they have history of GDM, they definitely should be checked and screened for to have a diabetes in future. But what is more important, that sometimes they have the normal sugar report, they will not follow your guideline to intervene them for prevention of diabetes. Suppose they are developing central obesity, they have already all the history of GDM, so it means they are future patient for diabetes. So that they don't follow. That's a very, very important reason. And you have written very rightly that global prevalence of hyperglycemia in pregnancy is 16.2. You have also written about the Southeast Asia, which is almost, from 16.2 to it's become 24.2. So the incidence in our region is very, very high as per the International Diabetic Federation data. And probably this is increasing over a period of time. Day and day, we are seeing that it's increasing. We all know about the GDM and its complication. And once you explain the patient as well as their caregiver, they become very, serious to take care during the pregnancy part. But if they are completely missed out, or they don't know about the hyperglycemia in pregnancy, or the late diagnosis itself will lead to all those complications which you have written in this particular slide. But more difficulty is to get them on a regular follow-up for prevention of diabetes, or explaining them that, this obesity, how they can prevent them, and how we can follow them regularly. That's really a big challenge, particularly in India, what I'm seeing in my clinical practice.
Thank you. Thank you. I think you made a very important point that when we first meet them and they are diagnosed with GDM, and I say we could be even a frontline health worker or a physician or anyone, community health worker, midwife, we, the knee-jerk response we have is this will go away as soon as the pregnancy is over, in a reassuring, way, and that makes them actually, have no real concern about the future risk of diabetes. And so I think talking to them about these long-term complications that can happen if they are not followed up in a properly worded way, in a sensitive way, I think it's very, very important. So, Madam Dr. Sabine, are women of reproductive age, are they healthy these days? And if it's your experience in Pakistan and
Thank you, Shah. This is very well known to all of us that the health these days is not just the physical health, but the mental health as well. And the burden of non-communicable diseases among reproductive age women, they are increasing every day. And as is very rightly said, that we all are suffering from not metabolic syndrome, but hyper-sitting syndrome. So when I ask my patients, please take this medication in the morning, so somebody attending with her will say, doctor, the morning starts at 1 p.m. So the breakfast starts at 1 p.m. So when to take the medication? So this is how the health burden is increasing every day, because we are not following what is required to be followed. And then I used to say that that once a woman is pregnant, she is also pregnant with her grandchild. And this is really true, and we all know that. So another thing, before I start saying anything about this high burden of health issues, which we all know, as Banshi very rightly said, that women are lost to follow up once once the pregnancy is over. And that we have seen a number of times. We saw it in our own study, which we did in World Diabetes Foundation. That is a published study. And we saw that only 20% of the women, in spite of very appropriate counseling, attended postpartum. So what we did and what we saw in few of the studies, there are about 6 studies published so far, and they say that do the OGTT when the woman is still in the hospital, on the first day, on the second day. What will happen? You may overdiagnose, but at least you will not miss any woman. Now, coming to my own topic of high burden of health issues, we know that early marriages, they are the promoter of the problems, And in our society, in India, in Pakistan, early marriages are very, very common in spite of so many laws and regulations. And now the morbidity, zero morbidity, you cannot say at any age. But as the woman ages, the multiple morbidity increases because she is entering into a phase of life as she ages, where she has not been taken care of earlier, in her earlier ages. So how can you expect, an analogy to the tree, that how can you expect a robust tree when the seedlings are not taken care of? And so is true, very true in our reproductive module. It's not only the mental, but also it's not only the physical, but the mental health also have to be taken care of. We must talk about breast carcinoma, which is very increasing. So is the cervical cancer, unsafe sex, reproductive health, maternal deaths, sexually transmitted disease. They all have to be taken into consideration in a holistic manner. Not only the sexual health, but all other health matters should be taken holistically to address the issues and to prevent morbidity and mortality as a woman starts her reproductive life and as she passes through her ages into the post-menopausal phase. So thank you very much, Usha. It is a great pleasure to talk on this forum and to be with all of you, so very august and knowledgeable speakers and our colleagues.
Since Dr. Samugavelu is not here, the question I had for him is, are young women of today having more metabolic health issues? Also, as a diabetologist, I asked him, are you seeing more women with pre-diabetes or metabolic syndrome? Either Purvi or Banshi, you can take this. So Purvi, you had mentioned when you were talking to me earlier this week,
so metabolic challenges in women are more. That's what we are seeing. There's no doubt about it. We are also seeing more obese and more metabolic syndrome with them. We also see a lot of PCOS. That's very common. And so young adolescent girl. Now we are getting a lot of reference from dermatologists too for their facial hair issue. And that's also very common. So these are the challenges which we can definitely say. And when we take their history, we see also a lot of menstrual irregularity because of PCOS. It's very commonly seen now, and it has really become very. If you check there for pre-diabetes, many of them you find that if you do their OGTT or you get their even HbA1c, you will find them it's coming 6. Even they don't even their fasting or post-meal sugar may be normal because we don't get OGTT very often. But now because of HbA1c, you can find that many of them have pre-diabetes too. Even before pre-pregnancy, when they come for the checkup. I also have some of the centers who are like IVF center. They normally send to me, even their sugar are coming normal before they plan for conception or for IVF or IUI. They send to us that, metabolically you correct for everything and then you send, or sometime you, after 3 months or 6 months, we will plan for her IVF or IUI. Just make sure that she lose some weight and that will help her for pregnancy. And when we just examine her or routinely we get all the reports, we find many of them are in pre-diabetes. Not only pre-diabetes, severe dyslipidemia. That's become sometimes challenge. A 40-year-old lady who is going and planning for a IVF, and you find there's a severe dyslipidemia. You know that LDL cholesterol is more than 160 now. What to do? Because that side, one side she's planning for a conception, and we don't give that lipid lowering agent too. So we see a lot of metabolic health issue. There's no doubt about it. But the only thing to prevent them, that we have to start educating them in a school. That's the only way. Long back I have suggested when I met the Honorable President in 2017 from Diabetes India, that the only way to educate these female that in NCERT itself, in their education curriculum in class 5 to 9, we should include health science as a booklet, as is a part of their course or is a curriculum that will educate for everything, not only the metabolic related or nutrition or obesity, even for infection, even for sexual health. Everything should be included in that book, from class 5 to 9. The only challenge they, after 5 years, when we again met and we again discussed with them, they said that who will make the curriculum for them? Who will make that what class 5 should read and what class 6 should read and what class 7? And whether again, male or female, they should read differently. I mean, that's real confusion. But I don't know, but that may be a one challenge and one solution also, because if we educate them at that, during that age, probably it can help to decrease metabolic health issue overall in society, particularly the young adults who are becoming obese, overweight, and many of them, there are a lot of other issues which can be solved.
Purvi, do you want to add something?
Yes.
Yes, ma'am. So, Dr. Banshi sir and I have had this discussion before, and the cumulative pre-diabetes states in women as compared to men also, I think is startling, because all these conditions are just pouring into diabetes, at an earlier age. So I think that awareness is very important, and I think webinars like this are important because we are getting our community, and now it's not just endocrinologists, physicians, and diabetologists. I think this needs to percolate down to primary care physicians as well, because that's the first interface, and that's where we can start to make a difference with highlighting some of these aspects and taking that forward in that group. But I think I'm loving the discussion so far, and you hit the nail in the first slide itself with highlighting obesity, which is undoubtedly the mother of all metabolic diseases.
So I want to just mention, and because when she brought it up, so Divas developed a program called Yuvadi function. Yuvadi is in Tamil also it's young woman, in Hindi also it's young woman, and it's also an acronym for young women's awareness of diabetes and also health initiative. So all of you are very correctly said it's not just metabolic health, it's not just diabetes, it's everything, sexual health, mental health, everything has to be included. So it's a 4-part educational program, 1 part on health, 1 part on nutrition and physical activity and sleep, 1 part on diabetes and gestational diabetes, and 1 part on preconception care. And this is for high school girls, college girls, young working women, people just ready to get married. So hopefully by the International Women's Day of this year, it will be ready to be launched. I keep you all in the loop. I'll move to the next question, which is, what are the barriers? Eventually, very clearly said, none of us are getting 100% of the women back after the postpartum follow-up. 100% is like a big number. I'm talking about even 50% pain will be thrilled. But they don't. And so what are the barriers you looking for that they're not following up?
Yes, madam. So, I mean, when it comes to the barriers, identifying the barriers to postpartum follow-up of the GDM care, there could be a multitude of factors, which could, negatively affect, having a smooth follow-up of these, of the mothers, who have had GDM during pregnancy. In general, I would like to look at it, from different angles. So first of all, I mean, from a national or from a country perspective, we have to have a robust system, a smooth system, so that, I mean, the continuity of care could be maintained. There should be a very, close, a linking between the primary health care and secondary and tertiary health care. Unless we have that, and at the time of discharge, proper advice needs to be given and proper documentation needs to be given. And especially in countries like, Sri Lanka, where here we don't have a proper referral and a back referral system. So from one end of the country, a mother could come from one end of the country, can go to a hospital which is located in the other end of the country for delivery. So at the time of, discharging this particular mother, it's really difficult to, get everything in place. How the follow-up is going to happen. Although the primary healthcare system is very robust in the country, a lot of practical issues might take place. So, all in all, at a policy level, we have to have a proper and, it has to be planned and everything, all the challenges and issues need to be anticipated and then addressed. So that is, the first angle, which I would like to look at this issue. And then there are a lot of personal issues, which have been listed out here. And for those personal issues also, there may be underlying reasons. Now, for example, misconceptions about, getting a label of, having diabetes and, the social, the stigma associated with these, these particular diagnoses. And then, the relationship with the spouse. And because we know that, in, rural, at village settings, the mothers are being neglected. So, the importance given, at a family level, to the mother, to the mother. So the social situations, the level of understanding, educational level, socioeconomic background, so many problems or issues may be there. These, we may not realize that there are fundamental issues underneath. Superficially, what we see is, how, the immediate or the superficial reasons for not having a proper follow-up with the healthcare system. So some of these would be, for social support may be inadequate. So that, to visit, to attend the clinics, there may be serious issues, practical issues, and also, there may not be private places or adequate privacy for the mother to breastfeed at these clinics. So a lot of practical issues. And if you can go to the previous slide. And as I said, the stigma associated with this particular diagnosis, and also, the financial situation. Certain things may not be available free of charge, because in Sri Lanka we have free healthcare to all, but because of the government clinics being crowded and all, sometimes people tend to do these things, for practical purposes from outside, and again they find that it's difficult because of the financial issues. So these are some of the things that I would like to highlight. And they really, some of the women, I think most of the women do not want to receive a diagnosis of diabetes after delivery, because they don't want to become a patient in general for the rest of one's life. So those are the misconceptions. So actually speaking, these misconceptions, underneath these misconceptions, miscommunications from a medical, healthcare perspective exist. So I think we need to identify all these issues, rather than looking at just, the immediate reasons for, not coming for clinics and not attending clinics. And we have to at a national level, at a policy level, the fundamental things need to be identified and addressed properly. So I think all in all, we do, this problem we have to take seriously. GDM we diagnose, we manage, and then we discharge. And, the rest of the things are forgotten most of the time. Even as clinicians, we tend to forget. So there we have to enable, this to happen, a smooth transition and long-term care. So as I said earlier, being a continuum, so the care shouldn't be stopped, shouldn't be ended right at delivery, and it has to be continued throughout the rest of the life, I would say.
That those list of barriers that we saw, that's from a focus group discussion we had with patients and women with TBI who had delivered, and when we asked them like why they didn't come, these were all the reasons they came up with. I think what is important is if we have this list in hand ahead of time, even before they go to delivery, if we can show them this checklist and say, will any of this apply? And if they say, I'm afraid I will lose a lot of blood, we can counsel them and say, you're not going to lose so much blood with the GTP, or any of the concerns that they have. And I think also, and absolutely we need to point it out that we need to have those spaces for breastfeeding or a child care. If they bring their other, the other child, who will be watching the child. So we need to start paying attention to those really important things. I don't see Bansi. Is he there? He may have left. This is on, do children of mothers who are overweight and obese, are they at risk for any long-term illnesses? Shall I take this quickly, or anybody else wants to talk about this? Could we? Shall I take this quickly?
Sure, ma'am. So definitely, I think, yeah, Rutul, go ahead.
We have Dr. Ami Sanghvi. She wanted to add something.
Ami, go ahead.
So I think wonderful webinar going on discussing about the health of every lady is important. I'm sure all on our panel will agree and agree to this, that it starts at home. It starts with every lady in our household to be taken care of. And ma'am, I'm sure you will agree to that. Taking care of these females is going to take us a long way. So we expect that whatever we have gathered today, we are going to be percolating it to help the physicians to look at these specific conditions in women alone, and those who with looking the way we look at women, their health is going to be looked at a little differently.
Ma'am, specifically to the question, thank you, Ami, for sharing that. Ami is our huge asset in our group and has already planned activities for further also. Pertinent to this particular question, I think definitely it was a while before we realized from very elegant studies conducted that yes, an overweight child is definitely, a child born to an obese mother is at risk for developing all these conditions much earlier on. And I think Professor Yajnik, sir, and many others in the field have done some pioneering work with respect to this to study the long-term outcomes. And clearly, obesity is one of the very prominent risk factors for perpetuating the cycle of metabolic disorders, feeding into metabolic dysfunction in the next generation also, and subsequently just moving forward with that. So I think the risk is just not limited to that. We know today that even type 2 diabetes, cardiovascular disease, and importantly, the new emerging aspect is metabolic dysfunction associated steatotic liver disease. All these are coming up as important complications or conditions that are arising from this single sort of risk factor seen in women. So again, coming down to that window of preconception or that period of preconception, care, awareness, education, action, I think we are coming down to that.
Just one point, and I want to ask Dr. Shabir. See, when we think of maternal obesity, right, we don't think of congenital malformations. We only think of it in GDM. But just see this, it's not only big babies. Mothers who are obese can also have babies with these kind of malformations. So, madam, I just want to ask you that Is it something you're concerned about?
Thank you, Dr. Usha. Actually, if you look at the fetal origin of maternal disease, this is a subject that is now coming up too much, and there are about 28 diseases which are of intrauterine origin, and obesity obviously important of all these. And an obese mother, as the pregnancy advances, can have obese child, and vice versa. And with subsequent pregnancies, the newborn tends to be bigger in size. So this obesity, and there are two spectrums of it. The child who is born dysmature or low birth weight, the mother tries to bring it to the weight of the other children, and that is more disastrous because intrauterine milieu has set that child on that smaller weight scale. And in extrauterine life, if that child is overfed or bottle fed, then that child tends to develop hypertension, obesity, diabetes, and cardiovascular problems and whatnot. So I think the best window of opportunity would be not to wait for the mother to attend in the postpartum period, as we all are trying to. Because in our clinical practice, being an obstetrician for the past 40 years, what I have seen is that the best time to advocate for maternal or child health care is the receptivity is when the woman is pregnant. She will abide whatever you say. Whatever problem she has to face by the in-laws, she will abide what you say. So I think that leaving for example, contraception, for example, oral glucose tolerance test in postpartum period, they are inviting for non-compliance. So the best thing would be to find the solution. What is the solution? Can we ask her for the point of care testing? Ask her to dissolve 75 grams of glucose in a glass of water and do a point of care testing with glucometer. So that can resolve the issue rather than leaving the issue unaddressed. So we have to find the ways, the solutions. Plus, the women, they go to their mother's houses in our culture, same as in India, and she rests for that period of 40 days and keeps on eating those oily things and desi ghee, which we call. So all these things they tend to put on the weight, and later if they try to reduce it, then it is very difficult. So at that time, in the postpartum period, with the child around, with the responsibility of the newborn, it is very difficult for women to attend in the postpartum period. So whatever we have to do, we have to take the opportunity of antenatal time and explain her everything that we want to make her understand about obesity, about childcare, and about her own blood glucose testing, I think.
Thank you, Dr. Purvi, in the interest of time, shall we conclude with this last thing, like what should be absolutely, stress upon the postpartum period, especially the fourth trimester, as we are calling the 120 days or so, or 90 days after having the baby. So, definitely, if they think you're asked to take some meditations, they need to focus on that. And then eat healthy and be physically active. Try to, not quickly bring their weight down, but gradually bring their weight to their postpartum weight. And then breastfeeding, which decreases the risk of. So 6 months of exclusive breastfeeding and a year and a half or year of complementary breastfeeding are the three measures that have been healthy lifestyle, healthy eating, physical activity, as much sleep as possible with the newborn, and of course, breastfeeding. So, what do you think? Should we stop here or continue?
Ma'am, that's great. I think we may stop here. We have one more talk to go, but we should reconvene, again in a few weeks and, talk about some more groundwork that we can do and how we can also work with you, ma'am, closely in your efforts and get our colleagues and stalwart experts from across Southeast Asia to chime in as well. Thank you very much, ma'am, for this and such lovely, beautiful slides and very pertinent questions brought out and excellent insights shared by our experts.
Thank you.
Thank you.
Dr. Thank you very much.
We have only
Thank
Dr.
you.
Bhakti Sabu to blame for this wonderful webinar. We have one more talk coming up, and I may request all those who can stay, please stay back. We have this wonderful talk by Dr. Deena Shrestha and Professor Shabin ma'am and Dr. Dimuthu. I understand it's late, but your presence today has been very, very encouraging to us. And the topics you brought forward were absolutely fantastic. So a very warm thanks from India, and we can't wait for the next physical meeting where we will connect again also to take some of these aspects forward. But I think very, very important points were highlighted today.
Purvi, you will meet Shabin in IDF.
Thank you, Bansi.
Yes.
Thank you very much, Bansi. And
Yes,
I
thank you,
hope that
madam.
next time for physical
Next time
meetings, we will meet somewhere in Dubai or some of those places.
Bangkok, we will meet in
yeah.
IDF.
We'll meet.
Yeah, sure. So thank you, Purvi. Thank you, Bansi.
ma'am.
And thank you, Dr. Gokalani, for your
Dr.
very...
Rutul.
Rutul, yeah, Rutul is here as compared to the second and third name.
We all will
Thank
meet
you,
you,
Dr.
madam.
Rutul, for your very kind compliments and appreciation of the talk. Thank you very much. So I'll stay back till the last speaker talks.
Yes, ma'am. And the topic is cardiovascular risk in polycystic ovarian syndrome, when to screen and how to treat.
When to screen, how to treat. This is going to be my topic for today. And this is clearly important in today's day and age, right? So the outline is going to be how is PCOS related to the cardiovascular disease, how and when should cardiovascular disease risk be assessed, and of course, how and when should they be treated. So how is PCOS really related to the cardiovascular risk, right? We want to know. So we know before, this is how we used to diagnose PCOS. Any two of the three, we could have clinical or biochemical hypoandrogenism, which can be both elevated testosterone or DHEAS, acne, hirsutism, or female pattern hair loss. Also, the second one would be oligo or anovulation, menstrual cycles of less than 21 or 35 days. Nowadays, you actually need to know what age group you are in to actually put that abnormal menstrual cycles in, and documentation of failure to ovulate by low mid-luteal progesterone. And the third one of the criteria was a polycystic ovarian morphology, depending on the ultrasound technology used and patient's age. But we know that today the world is changing, and we do from 2023 have this new way of diagnosing polycystic ovarian syndrome, in which the screening, diagnostic assessment, and the risk assessment and at the life stage. So we know that any kind of irregular cycles now with the clinical hypoandrogenism, we don't need to do anything. If we exclude other causes, we can actually call it the diagnosis of PCOS. Or if there is no clinical hypoandrogenism, right, just irregular menses, then we can do a test of biochemical hypoandrogenism. And of course, we want to exclude other causes, and that is the diagnosis. And then if there's only irregular cycles or hypoandrogenism, then what we can do is in adolescent, the ultrasound or AMH is not indicated. I know that AMH we were using, and it was not always, that AMH was not recommended. But now actually in adults in which we have irregular cycles or hypoandrogenism, not both of them, then actually we can use an ultrasound for the polycystic ovarian morphology or use an AMH level. And if positive, we can actually cause it the diagnosis of PCOS. I just wanted to put this slide in because, things are changing and we are moving from the conventional diagnosis to the new way of diagnosing PCOS. So we know that it's a polygenic disease, right? There are many genetic variants that confer with the risk of developing PCOS. It's not just one thing leading to a PCOS. And then there's also, and what we also know, and why it's relevant today's topic is that these same genetic variants also confer with the risk of early menarche, increased BMI, increased fasting insulin, increased triglycerides, increased incidence of type 2 diabetes, and of course coronary artery disease. So you know where this is leading to, right? And if you see the typical phenotype of a woman with a genetic risk of PCOS, and we see that the predictive risk score, which is based on the PCOS GWAS loci, if you see, is the same thing. You can see obesity and morbid obesity, type 2 diabetes, hypercholesterolemia, essential hypertension, and sleep apnea. So having said that, we know that the CVD risks, according to the American Cardiac Society or the American Heart Association, is elevated glucose, increased waist circumference, elevated blood pressure, elevated TG, and primary triglycerides, right? Or if you put in a risk calculator, what do we put, right? Blood pressure, cholesterol, diabetes. And that is we also know that the additional risk factors for CVD is early menarche, insulin resistance, and obesity. And so, as the previous slide, we know that PCOS is also a risk for CVD. So, because we saw, right, that PCOS does involve obesity, type 2 diabetes, hypertension, high cholesterol, and sleep apnea. So, how and when should cardiovascular disease be assessed in women with PCOS? The answer is upon diagnosis and routinely thereafter. So it really doesn't matter whether she's 18, whether she's 25, whether she's 33, and whether she's come just for the diagnosis of PCOS because, as we said, she just has some menstrual disturbance with some hirsutism, or she didn't have this, but as a 25-year-old, she came because she's obese and she wants to lose her weight. And then there's an opportunity, right? Or she's come because of fertility issues at 33. So it doesn't matter what reason she's come to your OPD and what age she comes at. It is a very good idea to assess her risk for CVD. So these are just a few more examples that, a 44-year-old can come because she's now complaining of female pattern hair loss. And then, or when she's 50, she's like, I'm having menopausal hot flushes, or a 61-year-old with a history for impaired glucose tolerance. So as long as we know that she has PCOS or has had or is recently diagnosed, we need to assess her CVD risk. So how to assess, right? So of course, as with all CVD risks, we know that we ask them, do you have a family history of early CVD? Has any woman or man in your family had a heart attack or a heart disease below 55 for a woman or below 65 for a man? Whether, you smoke, you have sleep apnea symptoms, or what are your diet and exercise habits? And today we will see that actually diet and exercise habits play an important role, especially when we are assessing it with a risk calculator. And of course, we can see the physical examinations. We can see, her height, her weight, the waist circumference, what is her blood pressure. And of course, according to these recommendations, they say every 3 to 5 years you can test. But I think every year or 2 years also for high-risk patients is not a bad idea to do an OGTT on an HbA1c, to check for dyslipidemia, and to go for a sleep study if we think that they have obstructive sleep apnea. Though we know with PCOS there is an increase in the testosterone can be, right? And it is casually linked to type 2 diabetes, but we don't recommend that. You should continuously test the testosterone. So how do we assess the CVD risk, right? So we know that metabolic syndrome can be 3 or 5 criteria: an increased waist circumference, more than 88 in non-Asian, and of course we are all Asian, so it has to be less than 80, the TG triglycerides of 150, a good cholesterol, the HDL of less than 50, blood pressure of more than 130 and 80, and of course elevated glucose. They don't have to reach the criteria of type 2 diabetes, but of course anything fasting more than 100 and a 2 hours or an OGTT of postprandial more than 7.8 and an HbA1c of 5.67 can be a risk for metabolic syndrome. So this is another one that we've added over here is, like how to measure your waist circumference. I know that Bangladesh and Bangladesh Endocrine Society is particularly also looking out for this, and they always emphasize this. And today, because we were talking about these risk factors in these women and how important it is for cardiovascular assessment, so I thought that we really need to make sure that we measure our waist circumference properly, right? So like it says, stand at a place and tape, put the measuring tape around the middle, just above your hip bones, right? And make sure it is horizontal, like not going up and down. Keep it snug, but not compressing the skin. And then measure your waist just after you breathe out. Because as we can see, these are in centimeters, right? So even a little makes a difference. So you might as well do it right when you're doing something that is important. So I have these two cases, and somehow for me also, this is an eye-opener, right? Because sometimes we just see a 33-year-old with PCOS and we think, okay, what is it like? Okay, you don't have a family history of CVD, and you're not smoking, no symptoms of sleep apnea. Okay, sometimes you go out, but your exercising and diet habits are not so good. And that is quite common, right? Because sometimes we tell these women, especially these 33-year-olds, and I tell them that, why don't you exercise? Go out, do something. And then they're like, I wake up at 5:30 in the morning. And you listen to the routine, how they wake up, they have to prepare food, they have to make their children ready for school, and then they have to go to office by 8 or 9, commute, come back at 5:36 after the office, and again cook. And I mean, sometimes I'm also like, okay, this is difficult, with like routine exercise. But of course, we know that we always encourage them to exercise, move around in your office, take 10,000 steps. I always tell them, in front of the computer, you can move your hands, do anything. But definitely, I know that it's not easy, but not also impossible. And then we check the physical examination. The blood pressure is around 30 to 85, which is not very high. And we can see that the height is an average of 5.2, like I'm a 5.3, so this is just average height for us. But she's a bit overweight, right? 88 kgs. That is good weight. And the waist circumference is 37. And then you test her, you say, okay, you know what, we should go for biochemical testing because you're a bit overweight, and so you have PCOS and you have some risk. So then we do our fasting, postprandial, we do an HbA1c, which is slightly elevated. And the lipids are also like, the total is about 206, LDL is 120, HDL is not bad. But when you look at this, you don't think, oh my God, like, you're going to get a heart attack. You don't think that, oh, wow, you really need to work it up, right? But if we put her diagnosis, we know that she's stage 1 hypertension. She has a bit of elevated triglycerides. So she does fit the metabolic syndrome because she does have 3 out of the 5 criteria. She is pre-diabetic, and obesity, she is class 2. So how do you assess these women below 40? Right? So what you can do is, I was, today when I was making this presentation, I myself was like, okay, the last time I checked my risk was like 2 years back. I was like, let me have a look, because it's interesting. And also the risk calculators have become much better. So you can use the ASCVD risk estimator, or this one also you would like is the Mayo Clinic. The ASCVD risk estimator actually gives you a lifetime risk estimate, but not a 10-year risk for people below 40. We really need to know that. And what they ask you is age, sex, blood pressure, cholesterols, and the history of whether you smoke, you have been hypertensive, you are on medicines, whether you take statins or you take aspirin. And when I went to the Mayo one, which was also good, it gives you a 30-year, it gives you also a risk factor, which I'll show you the results calculated. And it actually adds a little bit more, asks you whether you've had a stent put, heart disease, how much fruits you eat, and how much exercise you do. So it asked you 2 or 3 extra things. And then I put her numbers in there. And as you can see, that she, at 33 years of age, with only those kind of risk factors, had a lifetime SCVD risk of 39%. And if you go and Google, how do you break this risk character? Actually, she's in high risk because she's greater than 20%. And when I put her numbers in the Mayo one, her 30-year risk was 10%. And for heart disease, it was about 5%, right? So this is like a 30-year risk of cardiovascular disease. And if she were to control the risk factors, which was like they asked you to eat more nuts, exercise some more, you can reduce it to 5%. So this is Sita, who was 33, and we can say that her risk for lifetime was actually at high risk, right? So with these simple tools, you can actually calculate, and it's good. Then I'm like, okay, let's see case 2, right? She's Rumi, she's 61 years old with PCOS, right? Same things, you can put almost the same things, no family history, no cigarette smoking, no sleep apnea, rarely exercises, same diet, like doesn't take a lot of fruits and vegetables, but her blood pressure is, let's say, 150/90, like much more elevated, and her weight and height is the same. Okay, so she's like 5'2", and she's obesity class. And then you check her OGTT, and let's say it's a little bit more elevated, like she's 6.2, but not diabetic, still pre-diabetic, and her lipids are much higher, 275 of total, with an LDL of 189, right? So she's stage 2 hypertension. She has elevated triglycerides. She's also, of course, can be diagnosed as metabolic syndrome. Her LDL is pretty high, pre-diabetic, and obesity, same, class 2. Okay, so again, we use the same risk estimators, the ASCVD and the Mayo Clinic. And what do we see, right? You would think, oh, she's going to be at a much bigger risk. But if you see, her 10-year risk from a Mayo Clinic is 6.6. And if she does well, actually, she's 2.2. And if you check her ASCVD calculator, it is 6.6. You will not believe that today I actually put in the numbers at least 3 to 4 times, and I backed it, because I was like, I'm speaking this and I have to make sure that it is correct, and it is borderline. So this Rumi, who's 61 with PCOS, with hypertension, higher LDL, at a 10-year risk is 6.6, which we can call borderline. But Sita, who is only 33 with stage 1 hypertension and with a lower number of LDL, you can see her lifetime risk is high, right? So one thing what we cannot miss is that we have to pick these young adults, these women, these people at risk much earlier on. And we really need to learn how to use these tools as effectively as they can, because definitely sometimes with our judgment and our experience, we might just say, oh, okay, just lose a little bit of weight and that's fine, you're not at risk. But actually, when you see a younger person with these numbers is actually at high risk. So CVD prevention of PCOS in dyslipidemia, this is something from the ACE, and we can see that what are the enhancers for these ASCVD, right? So that we want to prevent heart disease. We don't want them to have cardiovascular disease. So what do we want to do is that we want to see that what enhances these risk factors. And that can be, of course, the family history, the high LDL, chronic kidney disease, metabolic syndrome, and people who are perimenopausal or have inflammatory diseases, and high triglycerides, and also in selective individuals, they've said an HSCRP, which nowadays I'm beginning to test in some of my patients. So and then you can see that this is a really nice way how they've broken down that whether you are 0 to 19, how to do it, 20 to 39, how to do it, and then 40 to 75, how to do it. So definitely, if you're from 0 to 19, you have a familial hypercholesterolemia, you want to give statins, right? How young, how old, I think is a topic for another day. But in age of 20 to 39, where Asita was, and she has 2 risk enhancers, right? Then you can see that we encourage her for lifestyle changes. Consider statin if the family history has a premature ASCVD and an LDL of more than 160, right? This is where it ends. And then as for Rumi, you can see that she's 61, so she fits into this category. And if her LDL is high and without diabetes, then what we do is, of course, with diabetes, it's another ballgame, right? So without diabetes, what we do is we do the risk calculator. So please use this. It's very, very easy, and it's on your phone. It's an app. It's very user friendly. And then you can see that if it's less than 5%, then you can tell them just, emphasize on lifestyle. If it is 5 to 7, where our Rumi was, we can actually consider statin therapy. And then for more than 7.5 and less than 20, which is intermittent risk, you can ask them to initiate a moderate intensity statin. Also here for primary prevention, you can see that up above, they've written, what they have said is if the LDL is more than 190, no risk assessment, just give them high intensity statins, right? And if they have diabetes, 40 to 75 years, then please give them moderate intensity statin. And diabetes mellitus and age 40 to 75, risk assessment to consider the high intensity statin. So after all this, I guess this is where we are going, that CVD prevention in PCOS is important, and metabolic syndrome, with impaired glucose tolerance, pre-diabetes, needs to be sorted. So what we are trying to do is see the risk factors were there, right? So the enhancers. So the one of the enhancers was metabolic syndrome, and part of that was impaired glucose tolerance or pre-diabetes. And we know for sure that there are multiple studies that have demonstrated the power of lifestyle, whether it's our DPP4, our DPP program, whether it's the touching study. We have seen that the long term, there's a reduction in the ASCVD risk up to 30 to 58%. Overall goal is weight reduction. And we know how these days obesity is now a disease and with its own complications, and weight goal, reaching your weight goal is important, or at least your weight reduction 10 to 15% has a significant impact on your health. And then there's also this way in which the pre-med study. I think we all have seen this, that, if you give them a controlled diet or you give them Mediterranean diet with extra virgin oil, and we've seen that definitely just diet itself can actually help reduce the risk factors, right? And the same thing with the DPP4. I keep saying DPP4, sorry, DPP4. It's like stuck in my head, just DPP, right? So but we know that lifestyle changes are hard, right? And for an Indian or a Nepali person to have Mediterranean diet is also not easy. But of course, we want to counsel them, encourage them, give them sources, refer them to your nutritionist. And if all that doesn't work, we know that there is good pharmacology therapy now, which we can recommend. So what do we want to do for Sita? 41, she was 33 actually, 33 years old. We tell her, for your hypertension, stick to lifestyle. For elevated triglycerides, also try medical nutrition therapy, see a dietitian, exercise. For your metabolic syndrome, pre-diabetes and obesity, you can take metformin, but we know with the DPP, not DPP4, that definitely metformin has has a role, but it is not as powerful as lifestyle, and you do have a higher risk. So please consider therapy and counseling, and keep following up with your blood tests and your doctor, right? And when it comes to Rumi, who's 61 years old with PCOS, what do we want to do? For her stage 2 hypertension, definitely lifestyle, and we want to start an ACE or an ARB, whatever we want. For the elevated triglycerides with the high LDL, as we saw, the ACE does recommend that we start with a moderate intensity statin, and of course, medical nutrition therapy. For the metabolic syndrome, it's the same. We can try pharmacotherapy and lifestyle, and we need to tell them that you do have, within the next 10 years, you do have a borderline risk of heart disease, and you should consider therapy and counseling, okay? So this is my last slide. Thank you everybody for your patience hearing. So, in conclusion, what we want to know, that definitely there's complex genetic relationship between PCOS, CVD risks, and the CVD, right? Women with PCOS are more likely to develop coronary vascular disease. Women with PCOS are more likely to have multiple CVD risk factors, and our job is to mitigate that. Our risk is to identify that. Our job is to make sure that we catch it early on and make them visualize it for them, help them see these risks and help them not fall into, not develop cardiovascular disease. Comprehension and routine assessment of CVD risk factors starting at diagnosis, anytime, any age is important. Personal and family history, lifestyle, of course, body mass index, blood pressure, the whole metabolic syndrome, the OGTT, fasting lipids, everything is important. So we need to assess that and make sure that whatever factors are enhancing the CVD risk, we mitigate it. That is blood pressure, lipids, metabolic parameters, especially the pre-diabetes and being overweight or obesity. Counseling always helps. I think that a lot of things can be sorted with talk. The more you talk to them, the more you help them understand. I think they're more accepting to the treatment and to the behavioral changes. And we've seen that in enough studies. So a team-based approach is also good. Nutrition services, ongoing evaluation for lifestyle, therapeutic outcomes, and counseling will be important. So thank you so much. And I hope you enjoyed the talk. I'm also taking this opportunity to welcome you all for our February Obesity Congress. It's held on 22nd in Kathmandu, and it will be nice to see you here. Thank you so much.
Fantastic talk by Dr. Deena Shrestha from Nepal. Unfortunately, she could not be with us live today as she is traveling and is at another assignment. May I request Dr. Ripan sir from our core team to share a few thoughts that he has and before we offer the vote of thanks.
Thank you, Pravi. Am I
Yes, sir, we can hear you.
clearly? Yeah.
Yes, sir, we can hear you.
Very nice webinar, I must say. It's so comprehensive, so learning for all of us. And what I do think personally that girls or women are naturally protected from diabetes. Number one, the genetic protection is always there. And if you does have any sort of bad trait, there's another process called axin activation. So they're usually protected. So even what I think that the adolescent girls should be picked up for any signs of hyperandrogenism, say acne, we often meet, they go to the skin specialist quite frequently, then ultimately they develop some signs of PCOS. So that is very important. Secondly, we need to screen those adolescent girls, number one, for obesity, number two, for any signs of hyperandrogenism. And secondly, when we screen an adolescent or young ladies for diabetes, we always do some of the school also, colleges also, we do RBS or FBS. That doesn't matter at all. We need to ask them to go for OGTT because this is the ICT is the first thing to be picked up. So I think that we need to adopt some policy to go to the school and pick up those girls early in the course of PCOS or any sort of androgen excess, and later on she might develop diabetes. This should be taken up in the earliest age because girls are the future mothers and the future of all of us. Yeah.
Thank you, sir, for those wonderful thoughts shared. I agree with you, but I think there is an urgent need for us to focus on women as not only suffering from metabolic disorders at different stages of their lives, but also the differences. So there are certain specific conditions to women like PCOS and others, but also the differences that we experience with respect to conditions like diabetes as compared to men. And I think this is what and cardiovascular disease as well.
Absolutely.
So I think that's what we need to appreciate and highlight because we don't have separate guidelines for anything as yet, but I think we are reaching there. I think that movement has begun and we need to add more momentum.
Very nice take up by all of you. It's a Diabetes India Mass Conversation. We're picking up a very important subject for all of us.
Thank you, sir, for always being encouraging and being part of our core team that is going to do this moving forward. Yes, Dr. Nimi, and then we can wind up.
I absolutely agree with you, Dr. Purvi ma'am, that it's not only metabolic disorders, but beyond that, And when we talk about women, we generally cater our thoughts and our efforts towards pregnancy, postpartum, and childbirth. But it's much more beyond that. It starts from adolescence time and goes way beyond menopausal times. And there are multiple factors and issues that needs attention, and not only ours as diabetologists, but gynecologist, obstetrician, and geriatric physicians as well, who needs to be involved and who needs to be taught and discussed about what should be done correctly, especially when we are talking about women.
Agree completely, Dr. Nimmi, and thank you for sharing those insights. We have a lot of work to do. So, without much ado, let me offer the vote of thanks. First of all, on behalf of Dr. Rutul and myself, we want to thank Dr. Banshi sir and Dr. Amit Gupta for this wonderful initiative and for helping us facilitate all our guest speakers from Pakistan, from Sri Lanka, as well as from Nepal, Professor Shabin Masood ma'am, Dr. Dimuthu Mutukuda, and Dr. Deena from Nepal, and also our stalwart expert, Dr. Usha Sriram ma'am, who joined us for the panel. I'm very thankful to Torrent Pharma also for supporting this, RX Events for conducting this, all of you core team members, Dr. Sunil Gupta sir also, who's an advisor to our group, and we always seek insights from him. Even moving forward, it will be critical to get his feedback. And I forgot to mention Dr. Meenakshi Bajaj ma'am, who's going to help us with very fine nuances on the nutritional front as well. So with that, I thank you all for joining in today, you lovely audience. I think you make everything worthwhile. Do write to us, do let us know what you felt and what you also feel that we should cover in our next webinar, and what kind of activities do you want us to undertake with respect to continuing medical education in this aspect. So thank you again, and I wish good evening to all of you.
Thank you and good night.
Good night.
Good night.
Good night.
Bye.
Good night. Thank you. Thank you.